Set. Good afternoon. My name is John Miller. Welcome to Rhythm Theater. I'm glad everyone is able to make it here and got here safely on the flights and so forth. We have a very distinguished panel of discussants, each having an individual presentation. This is sponsored by Cath Vision. It's a new company that has some very fancy amplifiers, some really nice signals, and some AI algorithms to help us analyze atrial fibrillation. So we're going to talk about all of those today. If I could go ahead here. So here are our presenters, Dr. Miguel Valderrama from Houston Methodist Hospital, Tom DePotter from University of Ulst, Larry Chinitz from NYU at Langone in New York City, and Pierre Jay from Bordeaux. And we're going to be talking about innovations in EP recording systems, not only recording systems getting nice signals, but also analytics to help us get better information out of our recordings. So we have the potential to increase efficacy, efficiency, safety, and outcomes as well with this new technology. A little background, we go back to the 1970s when you see some of us are old enough to remember these old mingograph recordings and spraying ink all over the place and getting, blowing your nose and it comes out blue at the end of the day, right? Yeah. And then we went digital in about 1988, 89. Our first system was around then. And now we've got some AI-based analytics starting in about 2020, and we're on the fringe of some really important stuff coming ahead. Now, if you have just standard EP recording systems, they're good. They have some pretty nice signals on them. But the data is not very clean. There's a lot of noise. The filtering detracts some information, especially a notch filter. And you apply artificial intelligence to those signals, those garbage signals, and what do you get out? You get garbage out. It's pretty garbage. Maybe it smells a little bit better, but it's still garbage. You can't really work with it. You can get something out of it, but not as much as you'd like. So the AI conundrum is that when we have garbage in, we get prettied, but still garbage out. Now, what if you come along with improved EP recording systems that give you clean, minimally filtered, data-rich electrograms that you can actually work with, plug those into an AI algorithm, and now you've got some good stuff. The diamond comes out the other side. Not garbage, but real stuff. So quality data in, quality analytics out. I want to show you some examples from one of my cases. These are exactly the same 2 QRS complexes, exactly the same 6 atrial cycles. One run on our standard LS Pro from Boston Scientific. And you see this is a very tiny signal here. I'm going to just highlight it here with an overlay. Really small fragmented signal. It's got an offset because the catheter is moving a little bit. A lot of noise on there. With the Cath Vision system, EC Genius, we see the same exact beats, and now we have a much cleaner signal here that is almost no background noise. These are filtered about the same. Sorry about that. These are filtered about the same. I'm just going to go back to that if I can here for a second. Sorry about that. The filtering on these is 30 to 500 hertz. Then we have a notch filter on our LS Pro. EC Genius does not need one. It's a clean enough signal as it is. So with that, I think we're going to go right into our first presentation by Dr. Valderrama. And I'm going to exit out of here and get back to his.
So I need to get the controller. I can get it.
Yeah.
I think trigger.
Oh, you are that. Okay.
Oh, there it is. All right, we'll try to figure this out. I guess those are my disclosures. And when it comes to what we can do better when we record electrical signals from the heart, it is a good idea to remind us what it is that we are getting, what kind of data, and where is the data that comes from the heart, and how is it generated. The cells of the heart just fire an action potential, and that's an intracellular phenomenon whereby the cells get depolarized. That, in turn, creates charge in the extracellular component that can be sampled. And a local electrogram is simply the voltage difference between two electrodes. Both of those are in the extracellular field, in the extracellular space. And those do not sample an action potential. They just sample the charges that are built up on the outside of the tissue. And what we see in an intracardiac electrogram is voltage differences between two such electrodes. Imagine we have a propagation like a flutter, like typical flutter, counterclockwise rotation around the tricuspid valve. And I'm going to set here 3 pairs of electrodes, 1, 2, 3, 4, and 5, 6. If the propagation is stopped at the time where I have stopped it, and the yellow part of the tissue is what's being polarized, electrodes 1 and 2 are in the same situation. So you will sample no voltage differences between those two. Electrodes 5 and 6 are sampling both of them activated tissue. There's no voltage difference between those two. Only electrodes 2 and 3 that are interface, that are in between the wavefront of propagation may sample a voltage difference. And that's what you will see. Cells just fire an action potential. If you have 2 electrodes on either side of the wavefront, you will sample a voltage difference. And how does it look? It looks like that. As the electrode polarizes, one electrode becomes charged relative to the other, and as the wavefront passes, that gets reversed. And then you see a positive deflection and a negative deflection. And we, by convention, call the activation time the peak negative deflection there. For bipolar electrodes and for unipolar electrodes, we have a different mechanism. But the idea here is that we are sampling voltage differences of the charges that get built up in the extracellular space as the tissue gets activated. So that's just the biological phenomenon. But then how do we sample it and how do we display it? The biological phenomenon is sampled using voltage differences between 2 electrodes that creates an analog signal. That's a continuous variable. Now we need to digitize it. And by digitizing, we convert it to a series of numbers that quantify the amplitude of that signal. And there's a few factors that we need to be familiarized with when understanding this. Sampling rate. How many samples per second do we get? The more samples per second we get, the more accurately our series of numbers will reflect the analog signal. There's also a concept of precision. How many degrees of numbers, how many numbers do we divide the signal into? For example, if we have a scale of 0 to 255, that would be an 8-bit scale, so we only can discriminate 256 levels of amplitude. So our signal is very crude, will be stepwise like in that bar graph. If we increase the precision, that requires more data being more heavier computational charges, task on the computer, but we gain in precision. We gain ability to discriminate minute differences in the amplitude of the signal. Obviously, we can go from 8-bit scales that only discriminates 256 levels to 24-bit scales that discriminates 16 million minute differences in amplitude. An important concept is the input range. The amplifiers can only sample certain magnitudes of voltage. Above those, we get saturation. This is a common phenomenon we experience in the EP lab when we pace, especially if we pace at high outputs, we saturate the signals. That's because our amplifiers have a limited input range. If our input range is large enough, we retain the ability to not saturate and discriminate those signals. And I'll show that in the next example here. Our signals in cardiac procedures are in the range of millivolts. Cath vision has a range of an input range of negative 1 volt to 1 plus 1 volt. So it's a huge, is really 3 orders of magnitude larger than we actually need to discriminate. So that enables the system to take pace signals, radio frequency ablation delivery, and not saturate the signal and still be able to discriminate minute differences in the voltage in our signals. So this is what the ECG Genius system does and allows you to get lower noise, compatible with a higher sampling rate, a higher input range, allows us to not lose the signal when we pace or when we deliver ablation. And as Dr. Miller alluded to, the richer data format allows us to implement AI algorithms without getting garbage in, garbage out. Won't get into the details as to how it compares to others. I just want to show you some examples. For those of you that are familiar with our work, we're interested in mapping coronary veins to delineate substrates of VT. That entails putting microelectrode catheters in small veins. Here I have an example of a patient undergoing a VT ablation with a large epicardial scar, low voltage scar, in a patchy way in the lateral wall of the left ventricle. And I have a decapolar catheter, decanav, in a large coronary vein. Let me see if this plays. No, it's not playing. And a smaller 2 French octopolar catheter in a smaller vein. And now I also have an epicardial octa-ray catheter sampling the signals. These are usually very small within the scar. These are displayed from the ECG Genius system. Notice first that the baseline is flat. It almost looks like falsely flat. It's very clean without any oscillations. When there's no activation, when there's nothing to be sampled, the baseline is very flat, and the electrograms are very crisp. I want to show you one thing. Pay attention here. I'm mapping this propagation, and I have the microelectrode catheter is in a small septal vein, distal to the decapolar catheter. Please notice the yellow signals, or the orange signals on the top right below the surface. Let me see if I can show you here. These are the signals shown recorded in the cath vision system. These are the same signals recorded with a BARD. Notice that the ventricular component has a very nicely distinct late potentials that are very sharp and very, very distinct compared to what we see with the BARD, where you just see squiggly noise. These are simultaneous, so these are the same signals processed and displayed in the ECG, in the cath vision system versus the BARD system. More examples here. Again, I'm mapping PVC signals in the epicardium versus the coronary sinus, and you can see this is signal displayed on the CARTOS system. Compare those with the signals displayed with the cath vision system. Very flat baseline, because when there's no events, when there's no voltage being sampled between those two electrodes, there's no signal and it's flat, and it's a clean baseline and very distinct sharp potentials. This becomes therapeutically relevant in certain occasions. It is not just how cute it is to have better signals. I'll show you one such example. This is a patient undergoing his third ablation of PVCs from the papillary muscle. And I get in there and I map with a decapolar catheter next to the anterolateral papillary muscle, and I get a signal about 20 milliseconds before the QRS. Seems like a legitimate target. And I can display, this is with the BARD system, but this is also, but showing you where I'm mapping. This is also from the cath vision system, 20-some milliseconds before the QRS. We ablate there, PVCs still are occurring. So we went back again and mapped with a multi-electrode catheter. Nobody would dispute the value of smaller electrodes and multiple electrodes to get better signals. But I want you to notice the signals that was recorded in the cath vision system that was not present in the BARD. A signal that precedes the QRS onset by 89 milliseconds before the QRS. You can see this, oops, sorry, let me go back. Let me see. Let me see. There. So the signal that I see here was not recordable on the BARD. The blue line in the BARD doesn't even show it. Let me see, actually, I noticed. So here, you could maybe guess that there's something there. But look at the same signal displayed in the cath vision. There's a clear, distinct potential here that precedes the QRS by 89 milliseconds. And that really made a therapeutic difference for these patients. So this is not just the cuteness of the display, it just has a therapeutic relevance for many patients. Similar example here, a patient with what we think is RV dysplasia, an epicardial VT that we were able to map just fine using an octa-ray catheter in the epicardium. Look at the mid-diastolic signals that we're displaying there. The annoying thing is that when we went with the ablation catheter to map and ablate these mid-diastolic signals, we could not see them because of the configuration of the 3.5 millimeter electrode of the ablation catheter as opposed to the microelectrodes of the octa-ray. So that that created a therapeutic problem. Then how do we now find those nice targets that I had delineated with the octave that I cannot see anymore with the ablation catheter? Well, this is an example. With the BART, I could not see it. And with the ECG Genius, so there's nothing here that I can see. Maybe it's really a very bad signal. But with the ECG Genius, I can resolve. Again, it's small. I don't overcome the limitations of a 3.5 millimeter electrode versus a half a millimeter electrode of the octave. But it does allow you to see signals that you otherwise would miss. And it has, like I said, therapeutic relevance. This allows the system to implement AI algorithms that I'm not going to get into because my colleagues following me will discuss this in more detail. But the idea here is that the quality of the raw data does matter when it comes to making therapeutic decisions and when it comes to implementing AI algorithms. And I'll stop there. Thank you very much.
Thank you, Miguel. Our next speaker is Dr. Tom DePotter, and he's going to be talking about a little bit more of the nuts and bolts of this new system. Tom DePotter from ELST.
Thank you. So, yeah, that's okay.
Oh, you okay with that?
So as indicated already, what we're discussing is an evolution of one of the fundamentals of the building blocks of every EP lab is, of course, the EP recording system. And as indicated, we're now in the era where we believe after decades, literally decades of little evolution, there is an opportunity and an opening for doing something new other than, like Miguel said, just making the signals prettier for their own sake. And what I'd like to do is show you a little bit what we mean by these AI-driven approaches and give you a few examples of why we believe that can be helpful and can be useful in daily practice. There are several aspects to AI-based analytics. I'm not going to discuss all of them. Pierre and Larry will cover parts of these as well. But in particular, specifically what CADvision is working on is approaches both to understand, assess, and potentially improve workflows for PV isolation, so aiding in understanding and classifying PV isolation, and then obviously beyond PV isolation, looking at the ever-growing patient population of candidates for procedures which we generally call PVI+, where we do something beyond PV isolation in the hope of improving outcomes for patients with very specific and typically very challenging arrhythmias. But having said that, back to the beginning, I think we can say historical perspective. By now, everybody in the audience, my co-chair in particular, is very much aware, of course, that AFib ablation and PV isolation is still the cornerstone of AFib ablation, is now more than 20 years old. The observation that the ectopic beats in the pulmonary veins initiate atrial fibrillation, in specifically paroxysmal atrial fibrillation patients, is still the foundation of a lot of procedures we do today. And regardless of the technology we use to approach this problem, the endpoint for our procedure, the validation of the job we set out to do, remains documenting this PV isolation. And although many would argue this is a relatively trivial task, it is not always and not necessarily so, and it is conceivable that we might actually improve our results by improving the certainty with which we are performing our procedure to begin with. If we are performing PV isolation and not achieving the result we set out to do, obviously the clinical outcome is going to suffer. Existing data shows that across the spectrum of available therapeutic modalities, across the spectrum of available energies. If we go look at remapping, we are well aware of the fact that no technology is perfect, that reconnection rates are reasonably comparable across the board, comparing laser balloon, cryo balloon, RF ablation, and PF, pulsed field ablation. And as indicated earlier, it may not necessarily always be the case that PV isolation and identification of PV isolation is a solved task, is a solved issue. Specifically, for example, for cryoballoon, I'm sure many of you remember the era where cryoballoon simply did not have a diagnostic tool, where there was no way to assess real-time PV isolation. And then when the diagnostic catheter was developed that allowed identification of real-time isolation, we soon discovered that this was not the straightforward task that we had in mind, that it depends a lot on where this diagnostic tool sits, and specifically for this therapeutic modality, specifically for cryoballoon ablation, often there is a trade-off between having the diagnostic catheter nice and deep, where it provides a lot of support and there is almost no artifact from the ongoing ablation, but there is nothing to record, of course, and having the diagnostic element in a proximal position where there's a lot of information to record, but the interpretation of the information is going to suffer a lot. There's going to be a lot of artifact. And this is perhaps not trivial when you consider the outcome. This is work from some of my friends in Middelheim in Antwerp University, I was going to say, but it's an academic center in Antwerp, where they showed that if you actually manage to identify real-time PV potentials during ongoing ablation and manage to identify real-time isolation, you impact clinical outcome in a positive way. And this is precisely what a next-generation EP recording system can help you do, and this is precisely what advanced signal processing can help you do. What you'll see in this movie is on top raw, so you have the ECG on top, and then in the blue the raw recorded signal, and in the yellow a conventional notch filtered signal. And no, I should say, sorry, the raw signal is on the bottom in green. In the middle is the notch filtered signal, and then you'll see what the processed signal tells you during the ongoing cryo application. So now you see the cryo freeze has started, and typically you see on the bottom you lose all information. On the top in blue you can still very nicely make out the PV potential, and you can see it splitting, and you will see the PV potential disappear. You will see it splitting as we speak, and now it is gone. The sharp component is gone. We have a complete loss of information on the conventional recordings, and we can clearly identify that we have indeed achieved the goal we set out to do, potentially with a positive impact on the patient's outcome. This is work that has been taken further into a more generic machine learning approach to assessing PV potentials during ongoing ablation, because the example I gave of interference of noise and artifacts is not exclusive to cryoballoon ablation, of course. And this is work that was developed by the group of Matthias Duitschaver and colleagues in Bruges and in Ghent University, where they developed a machine learning classifier to look at, to understand, to build a library of electrograms on the left before ablation, classify these EGMs into distinct morphological patterns, and look at, on the right, morphologies of EGMs as you can document it, as you can document them after PV isolation, and then build a classification system that allows an algorithm, an artificial intelligence algorithm, to judge whether a PV is isolated. And this is actually work that has been licensed and has been integrated into the EC Genius software as it is. The system, I say as it is, but the system is not commercially available, of course, but this has been integrated, technologically speaking, into the system that is being developed. This is what it looks like. So the interface you see here with electrograms, and you'll see a running movie in a second, which is going to make it a lot clearer. But basically what the system does is give you a snapshot, a template of your baseline, and then on the top you see these green bars, red and green bars. So when the system shows a red bar, the vein is not isolated. When it's green, the system considers it isolated, and just below that, the gray bars is the confidence that the classifier has in its own observation, is the confidence with which it is giving you this assessment. And so this is what it looks like in video. So again, keep your eye on the red and green bars. Left half of the screen you will see the template, and right half is the real-time running recording, of course. So ablation is ongoing, and what you will see in a minute, you see the delay, more delay. Now it's isolated. You see immediately the system detects something changed. So there is a very short lack of confidence, and immediately the next beat, the system indicates isolation. And you can see in the real-time screen and on the template that it keeps identifying for you how the signal looked like before isolation, and the real-time overlay to show you the actual EGM after isolation. This algorithm, this approach, as mentioned, developed and licensed and integrated in CAT-Vision, in ECGenius, has been studied in the P-Vision study, which will be presented at this meeting. The results are in a little bit under 100 patients. As you can see here under the screen, the area under the curve for overall accuracy of the system is 92%, as you can see. And interestingly, and I think this is of particular interest for this type of approach and this type of system, is that the way it was developed and it was trained is obviously on existing systems. The algorithm was trained with the recording systems we have, which means, let's say, second generation or analog systems. The results are good, which is no surprise because that's how the system was trained, and also PV, assessment of PV isolation is something we can do in our own heads with our own wetware, so it's not an inconceivable task. But what was shown is that if you retrospectively improve the input, like John said, if you increase the quality of the input data, and if you use the digitized ECGenius data to feed this algorithm, you can see that the results improve. And I think this is crucial for all the much more difficult things we're trying to do. If you think about all the incredibly complicated algorithms that we are developing, for example, to understand atrial fibrillation, where I think nobody is claiming that we in our heads can easily understand what's going on, it becomes easy to imagine that these systems will never achieve their true potential with the respectfully garbage EGMs we are feeding them. They need the best possible quality of signals to achieve their true potential. And I think this is what this slide also shows. Likewise and similarly so for PFA, of course. PFA is everywhere. PFA, as it is today, the devices we have typically are not known. They're known for many good things, but they're not typically known for their incredibly good signal quality. Very preliminary work has been done to assess the feasibility of using ECGenius and the PV isolation algorithm I just showed in the context of PFA ablation, specifically using the FARAWAVE catheter, where 5 electrodes, 5 bipoles are used on the equator of the device for EGM recording. And what you can see on the top right is that indeed the PV analyzer algorithm seems to be able to discriminate between no isolation on the left and then consecutive ablation steps as is recommended by the manufacturer of the device, of course, and on the end, isolation, which seems to simultaneously validate the feasibility of the algorithm as well as the usefulness or the applicability of these consecutive ablation steps. And here is one example of the signal quality you can expect or derive using these next generation recording systems, even in the context of raw data that is particularly troublesome to work with. On the right, you see how it looks like on a legacy recording system. In summary, for accurate and I think advanced analytics and advanced AI applications for difficult problems, I think the EC-Genius system is absolutely an essential step forward. I couldn't agree more. Garbage in, garbage out. Improve, less garbage in is going to be less garbage out. PV outcomes may be improved as shown through isolation, status classification, observation of real-time isolation. We believe there is opportunities, as we'll discuss in a second from next speakers, with predictive filtering of signal, of looking at response in ongoing ablation. And the system as is today, the PV isolation, seems to be accurate for both cryo and RF classification, may be translatable to PFA, although that is very limited. That's about 10 patients in so far. But overall, I think the main conclusion is machine learning needs the best quality data we can achieve. Thank you.
Thank you very much, Thomas. Our next speaker is Dr. Larry Chinitz from NYU Langone, talking about taking this to a next step. We've talked about how we get good signals, how the EC-Genius system is able to do some processing, and now let's get into how the procedure actually goes.
Thank you, John. Good afternoon. I'm really good with signals, but I'm not that great with this. So the importance of this meeting, in my opinion, is that I attended my first HRS in 1985. John was probably there at that time. And at that time, it was all about the signals. It was all about looking and analyzing signal quality and understanding what we were seeing, and we were learning it as we went along. And then we invested millions of dollars in three-dimensional mapping systems and creating things, and we forgot about electrograms, and they just got worse and worse. And the weakest link in my laboratory, which I consider a very sophisticated place, is our mapping system. So we need new tools to understand and to correlate with the things that we're doing, and I think that we have an opportunity here. So we've done about 30 patients with cath vision in patients with recent persistent atrial fibrillation. And we know that, at least I feel strongly, that persistent atrial fibrillation responds poorly to PVI alone. And we've developed a number of adjunctive strategies that have been pursued. Anatomical approaches, substrate-based approaches, mechanism-finding triggers. We're looking for these new ways of understanding persistent atrial fibrillation to go beyond PVI. But each of these techniques suffer with a lack of endpoints. We don't really know when we've done enough. We can't follow progress in ablation as we do these procedures, and we're not even sure what the endpoint should be. Should it be restoration of normal sinus rhythm when you ablate? Should it be changing other parameters that suggest that they will do well over time? We just don't know, and that's why we come to meetings like this and we see study after study where they say, do you believe in the posterior wall? Do you believe in this? And you can believe in whatever you want unless you understand what you're actually accomplishing. So the adjunctive strategies that we've seen over time, the surgical strategies of segmenting the atrium, the Cox-Maze procedure, which had some pretty significant effect, the MRI studies and substrate-based, looking at scar and trying to tailor our ablation to scar, or looking for triggers and areas of great interest that may perpetuate atrial fibrillation and allow us to ablate them selectively. But most of the data from all this stuff is post hoc. It's not an online analysis as you're in there ablating. Clearly a deficiency that we have. So this journey started in 2004, and we should all stop for a second and say thank you to my friend and colleague Piaget, who contributed so much to this. But we have a body of literature that has told us the importance of signal analysis, cycle length, dominant frequency, variability in those cycle length. So it started, I think, in 2004. Pierre and Michel showed us that if you do a stepwise approach to ablation of persistence, PVI, posterior wall, coronary sinus, we now in our laboratory, we call this old school, but if you take this old school approach and you watch the cycle length and you watch the degree of fragmentation and fractionation, that gave you a lot of information on who would actually convert to sinus rhythm. You couldn't really see it as you did it, but in post hoc analysis, it became clear that you could use those parameters to identify patients who you might be able to develop in sinus rhythm. A few years later, the group in Hamburg showed that some people convert to atrial tachycardias, some people convert to sinus rhythm. The AF cycle length could actually predict who would respond in one way or another. So you could risk stratify patients potentially. But again, it wasn't online, it wasn't as you were moving. The dominant frequency, again, by the Bordeaux group was now used to measure a similar thing. So if you could show a decrease in dominant frequency during the course of ablation, you could, again, predict which patients might do better and convert to sinus rhythm, and you could use that potentially in advance. And finally, work in the Michigan group with Fred Marotti and his group showed that during the course of a procedure, maybe you didn't have to achieve sinus rhythm, but if you decrease the dominant frequency by 11 or 12% during the course of that ablation, those patients did as well as the patients who, in fact, converted during the course of ablation. But again, it was not online, it was post hoc, and we've learned a lot, but we need to see as we do so we can produce it. So the cardiolytics module of the CathVision recording system offers a unique opportunity, a very unique opportunity, to take upon these agreed upon parameters, cycle length, variability, fractionation, dominant frequency, and see it in real time as we ablate by the creation of this heat map, which gives you a 15-minute illustration of what's going on in your procedure, and it updates every 5 seconds to show the effect of ablation in individual parts of the heart on actually what's happening to these variable parameters. So it is integrated in a recording system. So you can see the standard features on the bottom of intracardiac electrograms with signal quality that has already been described by my colleagues as being substantially improved with the potential for greater improvement as our AI algorithms develop. But at the same time, you get this heat map, which lists those parameters, cycle length, fractionation, cycle length variability, dominant frequency, right in front of you. And it's color-coded. The red colors being greater degree of disorganization, faster cycle lengths, more frequency abnormalities. And as they turn blue or to those other colors, it shows regularization that occurs as you ablate. And it's not just dark blue or dark red, but there's actually gradations in the color to highlight the manifestations or the magnitude of those changes as you develop. So I will say that in the 30 patients that we have done, obviously, we're not acting on this. This is all collected in the background. So I don't have any experience of using this directly to say that this is helpful, I'm going to ablate here more, but we hope to do that very soon. But we've accumulated a lot of data, which I think is very important to us. So the system uses these algorithms to be able to measure activation time. It samples a large number and figures out where is the best place to determine cycle length. Then it uses those individual signals to determine fractionation, and then it takes all of that data to create a spectrum tracking. We also can measure the cycle length variability quite accurately. So the data is not garbage, but in fact it's real data, and it's going into the creation of this visualization to help aid us in catheter ablation of persistent arrhythmias. So, the big picture, real-time, high-quality electrograms, fed into the system to create an activation analysis, a waveform analysis, a frequency analysis, do the statistical normalization, and develop this heat map. So this is our first experience with our patients, and these are all patients. This is cycle length. These are all patients with persistent atrial fibrillation. So first, I would ask you to look at the variability in cycle length. This is a baseline 5-minute recording before we do anything. The variability in the baseline cycle length of patients with atrial fibrillation is huge. And with an individual patient, you can see some vary very little and some vary a lot. So clearly not everybody with persistent atrial fibrillation is the same. Remember, persistent fibrillation is a clinical diagnosis. It's not a physiologic or an anatomic one. So you could have a persistent who acts just like a fresh paroxysmal. They're very different. And the variations in the cycle length that you see here are reflective of that, which makes you think, maybe I shouldn't do every patient the same, right? Maybe patients are really different, just like they're personally different. Their AF is probably different, and I have to take a tailored approach. So in the 8 out of the 12 first patients, we were able to show that there was a change in cycle length from the beginning of the procedure to the end. I will tell you that our procedure in this group of patients was PVI followed by posterior wall isolation. And then unless there was tremendous amount of scar visible to us, we cardioverted at that time and then went on after that. So this is not the stepwise approach that Pierre had described, but we ended predominantly after posterior wall isolation. So maybe we would have uncovered better data if we kept going in that, and I think that that should be something that we do. But you can see that there were 8 out of the 12 patients had a significant change in cycle length during the course of their procedure. And it wasn't just in cycle length. There was a significant change in the fractionation index that we saw, sometimes from 50% down to 20%. You would never be able to, with your eye, to look at the electrograms on your coronary sinus catheter and see those changes. That does not mean that they're not real changes, but you can't really see them online without a recording system that helps you to do that. But we showed that the changes occurred, and they occurred frequently, and now we have to show that we can make a difference. By the way, the electrograms are taken from a duodeca catheter positioned in the coronary sinus with the proximal electrodes in the right atrium and the distal electrodes in the coronary sinus so that we could see, and in fact we have proximal and distal recordings, so theoretically you're measuring the changes in right atrium and left atrium as you ablate in the left atrium. So really quite powerful. So here's an example of one of our cases, and you'll see, let's see, can I start this? You can see as we ablate, and it started with the PVI, initially there was lots of variability, fast, slow, but as we completed the PVI, as we completed the posterior wall, I think you can clearly see that there's a change towards, I wouldn't call it regularization, but the parameters of cycle length and fractionation started to turn blue, started to remain consistently blue, suggesting that we were impactful on the physiology and the mechanism of the arrhythmia. And then as we got to the very end, prior to cardioversion, it became really very stable, very robust, with much less variability as we saw. So, you know, I find it fascinating to see these things. I'm looking forward to the opportunity to be able to correlate what we do with what actually happens. But I think that there'll be a lot of potential for this through a lot of centers. So this was given to me by my colleague, Dr. DePotter. And this was a case of his who was a redo, I believe. PVI was performed, patient came back with atrial fibrillation. They were hoping to identify drivers, sites that might have perpetuated the arrhythmia. And he was ablating on the septum. And here, just as he ablated on this septal area, you can see an abrupt change in these parameters. An abrupt change in the cycle length, cycle length variability, both in the proximal and the distal electrodes, directly related, just as I was hoping to do, to that area of ablation. And if you looked at the electrograms at that time, you could, you know, in retrospect, you could say, oh, look, here was 2 wavefronts, he made it a single wavefront. I'm sure that I would not have noticed that as I was going on, but here's a nice example of the system being able to tell you that change. So I imagine that that patient's been in sinus rhythm forever, since that time. Yeah. So in summary, signal complexity gives us an opportunity to measure and track atrial fibrillation rhythm parameters and progress as you ablate. The relationship change in these parameters to acute procedural success and long-term outcomes clearly remains to be evaluated and to determine, but at least we now have a tool of which to do that. It may help us do more. It may tell us to do less. It may allow us to choose patients better. You know, long-standing persistence everybody shies away from, but there's some long-standing persistence who look just like recent persistence, and it would be nice if we knew that in advance. We could measure the effects as we move along. We can correlate it to long-term outcomes, and maybe we should start looking in other places other than the coronary sinus. All of Pierre's initial work was in the appendage, right? Yeah, so maybe that will be the next step in what we do. So I thank you for your attention.
Thank you.
You broke it,
In
Peter.
Jody. Yeah,
You're back.
On Jody's?
this one. Yeah.
Is this what you need? No?
No.
Okay.
Yeah.
There it is.
Thank you, John.
Okay.
Thank you so much.
So Pierre-J is going to talk to us now about the future of AI-based analytics.
Thank you very much. It's been very exciting and inspiring, and I very much agree with everything that has been said before, and I would like to emphasize that when we work nowadays, we work with a navigation system that displays colors, but those colors are from the interpretation that the system is doing of the electrogram that we are collecting. And being able to analyze the electrograms is still a strength, and maybe a skill that is progressively disappearing, unfortunately. So having a system that is able to do that for us is probably very relevant and helpful. Now, why improving EP recording systems? Well, the low noise that has been emphasized before that comes with this system is remarkable and super helpful. Noise is always a problem. Increasing the amount of electrodes is also something we need. We will have in the future sophisticated mapping catheters with more and more electrodes. As they get smaller, you can have more electrodes. And this is important. I'll show you why. Now, one of the things I found remarkable was the vision by Cat Vision is that they've been able to partner with CoreMap, and I will present some illustration of that. It's rare that you see two startup companies partnering. I think it's super smart, and thank you for doing that because it's particularly relevant here. And I suspect this will expand to other companies. And then AI empowered is, of course, important. This is an animal model of a myocardial infarction we have been working with in Bordeaux at Lyric. And you can see this tiny signal here. It's a light potential that is visible with the EC Genius, and that is not in the Lab System Pro. You can also tell the difference when it comes to the baseline, as previously said. It's quite remarkable difference, and of course those potentials are important because in our VT patients, they matter a lot. They are targets, and they reverse as you get the VT starting. This is an example of how blind we may be based on the type of electrodes we are using. So in this case, it was a very complicated AF ablation case. And this is the RF trace here. And here is the pathway. Of course, very different electrodes, right? In this artifact here is the mechanical contact between the RF catheter and one of the branches of the pathway, telling you that they are exactly the same at the same place because they are touching each other, right? There is absolutely no signal on the pathway, on the RF catheter, and you have these nice signals here visible on the pathway. This is due to the type of electrodes. And mapping with an ablation catheter is the worst thing you can do. It's blind to plenty of information. And in this case, we ablated in an area that showed no signal on the ablation electrode, right? So it's only because of the pathway information that we could ablate successfully that focal atrial tachycardia that was coming from the posterior wall of the patient. So this may account for some failures, and it's really important to understand that. Same thing here, where we've got an even more extreme demonstration of this quest for the invisible when we are using the wrong electrodes. So what happened here, that's again a focal atrial tachycardia in the context of AF ablation. This is the signal we've got here with the ablation catheter, and it's very far-field in nature. Far-field is typically a low-frequency signal, so it's everything but sharp. You see this rounded slope of the signal. It indicates it comes from a distance. So because the electrode has some antenna effect, it's able to record it, but it's coming from far away. In far away on this location, we're in the superior septum. It could be from the left atrium, but the left atrium corresponding or facing side is all gray here. So even the PanTray did not record anything there, and yet ablation was successful here. So my point is that we're lacking appropriate mapping catheters. And I'm not saying that far field is useless. Far field is super helpful, but you have to understand when it is far field, it has to be identified as such, and you have to understand when it is near field. And here again, so you've seen that. This is very interesting because this is after the first delivery using pulse field ablation. Now, pulse field ablation is very different from RF, and you can't work with pulse field the way you work with RF because the impact on the signal is completely different. So there is a massive stunning effect, which in fact means that at the present time, at least, with the current tools, we don't know what to do with the electrograms we record after the ablation because pretty much everything vanished. And it doesn't mean that it's going to be stable. If you just give one far pulse delivery, you're 100% sure that you will have a PV reconnection, even though acutely it's all blank. So this is a complete shift in paradigm here. Now, are these signal, this very tiny signal after delivery of PF relevant clinically? I don't know, but there might be. There has been some demonstration in the past that with RF they were relevant. So this work by the group of Marcus Dacaret was very interesting in my opinion, where he did this very careful remapping after a successful acute PVI using RF point by point, all right? And what he found is that those very tiny signals here that were recorded in some areas in the encirclement were in fact predictive of connection of the veins. And further ablation there improved the outcome. Is this going to happen with PF? I don't know, but I know it's relevant with RF. So good that we have a better EP system that is able to pick that up. Now, far field again is not a problem as long as you understand it is far field. It's particularly difficult to do so in atrial fibrillation. It's all chaotic. It's all fractionated, or fractionation is a very common finding. And we don't know whether this is far field or what it is exactly. What is the meaning of that fractionation, right? Now, this is an interesting work we did with Biosense at Lyric in Bordeaux in animals. And I'm holding the PanTray spline, and right next to it, the probe that Biosense developed with smaller electrodes and smaller interelectrode distance, right? So Panta is the PanTray, of course, and these are the probe signal. And you see that the complexity we have here is completely gone in the small electrodes and small interelectrode distance. So because of that, you start wondering, well, what is fractionation really? Meaning during atrial fibrillation, there is a good chance that it's an artifact. It's the addition of, activation that happens in the antenna sphere of the PanTray electrodes, and that are artificially added in the same bipole. And this is where garbage in, garbage out is even more meaningful. I mean, if we process these signals, I don't think we will ever be able to map atrial fibrillation. We have to have signal with no artifacts such as fractionation coming from antenna far field effect to be able to map atrial fibrillation if atrial fibrillation is a mappable rhythm, which I'm not entirely sure at the present time. But I'm sure that if we have a chance to be successful, it's using both the combination of very high-level EP system was this type of catheter that Peter Spector was smart enough to develop. So this is COMAP technology, where you have the electrodes that are on top of each other with some insulation in between the two, so that they have the same far field signal. And if you subtract one from the other, you just are left with this tiny area here. That is the area in contact with the lower electrode. So the one that is touching the tissue, right? So it virtually eliminates completely the far field. There might be some limitations, but it's a huge change as compared to current technology. If you look at the tracing, this is here color-coded the tracing from the COMAP electrodes, and this is from the HD grid. Again, I'm holding both at the same area in this animal model. Here you have some disorganization that appears on the HD grid that is not visible at all on the COMAP electrodes. And you have a shortening of the cycle lengths there, but it doesn't result in any fractionation. So the benefit I see here is that you can really annotate every activation. And you can start working on something that is solid as compared to interpretation of fractionation, which in my opinion is garbage. So this is the kind of signal you get. You may see here that the cycle length is quite different from that part of the recording, where it's slightly longer by 10 milliseconds. Different areas, different cycle lengths. You start to think maybe I can identify areas with shorter cycle lengths that may act as drivers and target that for my persistent AF patients. And really it's remarkable that virtually most, if not all, fractionation has gone with these electrodes. It's opening a new field for mapping atrial fibrillation, in my opinion. So thank you again for partnering. And so this has been mentioned earlier. And you see that this approach that targets these areas that are supposed to be drivers and focal areas driving atrial fibrillation resulted in a pretty interesting outcome in this experience. So I thank you very much. I'm sorry, very little time left for discussion.
Right, all right. Thank you. Well, we've heard today about this new analytical system. It's a new recording system, but it's more than that. It's an analytical system as well. We've seen with Dr. Valderrama that good signals make a huge difference in what we can do during a procedure. We've seen from Dr. Jay that signals that are not evident with our current technologies can make a huge difference in acute and chronic outcomes, more than likely. We've seen some very interesting work with Dr. Chinitz about what analytics can do with good, clean signals, and some of the foundation was laid by Dr. Potter here. And I have to think that this gives us an opportunity to go a quantum leap beyond where we are now. We've been complacent with some really okay, but not excellent signals. And the more we delve into these crazy atrial attacks and VTs, scar-related arrhythmias, with very, very small signals, the more reliant we are on the validity of our data. And we're seeing now with some of this information that we're missing a lot. It's either hidden by noise or it's just not there, not visible to us with any known technology. And with cleaner signals, now we have something that we can work with directly, clinically, and with these clean signals being input into AI algorithms, it really opens up a vast number of opportunities. We looked at 4 different parameters here: cycle length, variability, electrogram fractionation, complexity. There may be others that may be useful, but we have to start with clean signals. And now we have clean signals, and this really opens up a lot of opportunities. I thank all of the speakers for their time and effort. I thank Cath Vision for putting this on and for doing their due diligence and getting things right, and for our partners with Heart Rhythm Society at allowing us to have this meeting. I'd open it up for any questions. I have a question for Thomas right off. you showed this very beautiful elimination of the pulmonary vein potentials, and the signal, the bar goes from red to green when the signal disappears, and then we have dissociated potentials coming along. And it somehow knew that it should ignore those. Well, what's behind that? Do you know?
Yeah, so the data behind that is AI, is machine learning that, as mentioned, was licensed by CatVision. That if you remember the template where you can see the relation,
Between
it's,
the
it's
A
what
and
you
the
do in
PV.
your head. It's you understand which is the near field, which is the far field. You see that it changed, and it doesn't matter if there's a dissociated potential. If you have a consistent dissociated potential at the spot where the PV is supposed to be, it would
pick it up.
start failing. It would identify lack of confidence. But that's a scenario where you and I would also struggle. We'd have to do
Yes.
something.
Yes, you'd have to make some manipulation to
Yes.
separate those. So it's not just the mere presence of a signal that it sees. It's not dumb like that. It knows that it's looking for a relationship between the existing regular signal and where it was. Are there questions? Yes. Are there microphones?
Didn't help.
I would like to ask you all, and then just the Iraq point ablation is the more important, or some substrate modification, or potential driver ablation is important. Which one is more important?
Pierre or?
Yeah, that's a very good question. My answer to that is there's part of the job we can do by having a predetermined set of ablation, like PVI, for example, is purely anatomical, and yet it works very well. I still think lines and Marshall vein alkalization is part of that strategy that is predetermined. And then you have patients in whom this is not enough, and that, because of persisting drivers, whatever they are, focal or reentrant. And here, having superior mapping capabilities is super important. So I think it's going to be a mix of the two. And very likely, because it's easier to implement, the anatomical strategy will be deployed first. And then you will need the adjunct of very, very good mapping capabilities.
Other questions? Well, if there are none, then we'll dismiss. Thank you for your attention and coming today, and have great meetings.
Thank you.